Our thesis is that when it comes to plaque or blood clots, inflammation's at the root of it, and this is a systemic thing going on.
Yeah.
Let's start talking about what we do for prevention. Somebody's on the continuum, whether or not they're young and healthy, no plaque, or they're more advanced and they do have plaque, but they're ready to take this seriously and make the changes. How do you begin with the patient?
We always do a history and physical first. The history is important. So what other conditions does he have that could be contributing to his hardening of the arteries? So we know, for example, smoking. I don't need to beat that horse down. We already know about that. You got to quit smoking because smoking contains 7,000 different chemicals in it. We don't know which ones even destroy the arteries, but to me, they all destroy the arteries. So smoking. Diabetes. It's not just diabetes, it's pre-diabetes. And I think I've beat that horse down a lot too, because look, by the time you have diabetes, you have systemic atherosclerosis. Take that. You have to memorize that. By the time you're diabetic, you already have widespread atherosclerosis. So we look for that, okay? But I'm also looking for pre-diabetes. And how did this happen? I'm going to explain to you how this all happened. It all happened right here in my clinic. These patients were coming back with more disease. And like you just said, what am I going to do for prevention? So I did the blood work and none of them were diabetics, but the sugars were running around 100. So I did a glucose tolerance test on them and they were abnormal. And they had not diabetic levels of blood sugars, but what we call glucose intolerance. So the fasting glucose was high or the glucose went up to 200 and took longer than 2 hours to come down. So I identified these patients. Then what I did is I took a bunch of my patients in whom I did stents, and I looked at 100 of these patients, and I found that 70% of them who were not diabetic had insulin resistance, meaning they had high blood sugar problems. They were not diabetic, but they were pre-diabetic. We didn't know about insulin in those days. Because I'm very old. I'm talking about 20 years ago. After that, I started measuring insulin levels because I got a little wiser and I started doing what is known as a Kraft test here in my office where we were measuring insulin levels. And I found that these 70% of the patients who had pre-diabetes, what they call pre-diabetes, had extremely high insulin levels. So in spite of the sugars being decent, had so much insulin, and that seemed to identify a whole group of patients who were extremely high risk of having a new event, another stent, progressive disease, increasing coronary calcium, heart attack rates. So your metabolic condition, the biggest metabolic condition I found was prediabetes. So let's say a patient comes and says, I want to know what's going on. I'm going to be looking at that. I order a hemoglobin A1C. That's a test for diabetes. Comes back normal. Normal meaning less than 5.7. Doesn't mean anything to me. If you got coronary disease, even though your hemoglobin A1C is less than 5.7, if you have coronary artery disease, you need to do the insulin test. That's a blanket statement I've made, but I stick by that because you'll be surprised how many patients have normal hemoglobin A1Cs, but the insulin levels are still high because they got coronary artery disease. If you got coronary artery disease, you have to rule out hyperinsulinemia. If it's between 5.7 and 6.4, they'll say you got prediabetes. So what? Measure the insulin level, and it'll be exceedingly high. The way you do that, you drink sugar water, measure the glucose and the insulin level half an hour, 1 hour, and 2 hours later. It's a standard test that we do. Once I identify hyperinsulinemia, give me a drug that's going to bring insulin levels down. There is no drug. There's no drug to bring insulin levels down. I can bring your hemoglobin A1C down. I can give you diabetes medication that'll bring your sugar level down. But none of those medicines will also bring your insulin levels down because you have insulin resistance. This is a problem that I run into, not only with patients, but with my own colleagues and other subspecialists in other fields of medicine. The hyperinsulinemia is deadly. And whenever I bring insulin levels down, the patient's outcomes are better. How do I bring it down? Well, I'm just going to tell you the brief treatment, and we can come back to this. It's basically fasting. And I've done lots of videos on this, and I've seen drastic changes in the patients because the insulin levels come way down. The patients feel and look great. And guess what? They stop coming. Well, they come for regular checkups, but it's now once a year and it's goodbye. So insulin. So I'm always going to look at your metabolic condition. I'm going to look at your hemoglobin A1C, your insulin levels. I'm going to look for a fatty liver. What's a cardiologist looking at a fatty liver for? Metabolic disease. If you have high insulin levels, you're going to have a fatty liver. There's only 3 reasons why you can get a fatty liver these days. And by the way, almost 3/4 of us have a fatty liver, which is really not a good thing. It's either because you're an alcoholic, or you're drinking too much, or you have other toxins in your body, or you have hyperinsulinemia, or what I call these days is leaky gut, but call it intestinal permeability, which we'll talk about, because all that inflammation from the gut has to first be processed in the liver. So this is going to lead to a big conversation, and I can already see that your mind's spinning with this, because if you got a fatty liver, you better know why you got it. And you have to turn over every stone and look to see why this patient's got a fatty liver, because fatty liver is linked to coronary artery disease, hypertension, stroke, dementia, premature aging, even cancers. And yet, it is probably one of the most overlooked things. So I always order a liver ultrasound to look for it. There's another way to do it also, which is you can order a CT scan and it looks at visceral fat. Very important. And you need to have a distinction in your mind between visceral fat and how malignant that is compared to subcutaneous fat. Because I see patients in my office all the time. They're obese. They got fat all over. But metabolically, they're perfectly healthy. They don't have visceral fat. They don't have a fatty liver. They're just fat. That's it. So those are metabolically healthy patients. And they don't have coronary artery disease. And even if they do, the coronary calcium score is very low, because sometimes as we age, we can also build up some coronary calcium too. But they're not pervasively sick the way the metabolic patients are, where they have a fatty liver and they'll always have a protuberant abdomen. Protuberant abdomen where you can't pinch the fat. Protuberant abdomen that's taut. So I can walk into the room and tell which patient's got a fatty liver and which one's got a visceral fat, and which patient therefore is metabolically abnormal. He's going to have a high insulin level. So we do the liver ultrasound.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
A lot of coronary artery disease is very silent. That plaque is silently sitting there in millions of people without them even knowing. And there are ways to find this out now. We have the technology. It's just not being